All right, so I figured I'd show some cases and hopefully explain how I would use these different types of technologies and I think the benefits. So the first patient's one of my patients with a grade 3 well-differentiated neuroendocrine tumor.
So the metastatic neuroendocrine, what was your plan for this going into it? Like,
when I look at these sorts of referrals, my first question is, can I be ablative, right? And so whether that's percutaneous ablation or using ablative radioembolization, that's what I always think because I think that's going to be the best for the patient. Now, as you can see here, multifocal bilobar, there's innumerable metastases. This is a very common neuroendocrine appearance. So I don't think I can be ablative here. And so the next thing I have to think about is, can I deliver an effective amount of dose, in this case radiation, to the tumors without worrying about damaging the background liver? And so that's my first thought, that this guy's going to be likely staged bilobar radioembolization.
Got it.
And so that's what we did. As you can see here, we have 2 cone beam CTs from each of the embolizations, showing that there are hypervascular tumors. We treated the right lobe first, and then we treated the left lobe second. Relatively similar distributions of the tumors by lobar, and again, they're quite small. They're taking up very small parts of the liver. And so I ended up treating this using 2 different approaches. So the one on the right, the artery was too big for me to use a microvalve. And so I ended up just using my 2,4 Prograde. And both of these were treated with resin microspheres, 3-day precalibrated. And on the right-hand side, you can see there's a ton of uptake in the background liver. And you do see kind of focal areas of uptake inside of the tumor. But you really do see a decent degree of uptake in the background liver. On the left-hand side, I did end up using a microvalve on this case, and you can see there really is just focal uptake inside of the tumors with very minimal background liver uptake. And both of these were treated with 3-day precalibrated resin microspheres and the same partition dosimetry. So really the only variable I changed here was, I guess, 1 month in time between these and the microvalve that we used. And so this really shows the ability to decrease the background liver uptake. There's no randomized controlled trials that show the benefit of all of this. There are some interesting trials, particularly Pasiak et al., that looked at MAA studies and the difference between an end-hole catheter and a microvalve and showed that not only does the tumor dose go up by 20 to 90%, depending on the patient, but the background liver dose also goes down by a similar amount there as well. So there is some prospective data. Again, no phase 3 randomized trial, but once you see pictures like this, it's pretty convincing that there is something happening here.
Let me ask you this also. So I have a couple of questions about this. How big was the vessel, ballpark, to where you couldn't use the microvalve catheter?
About 6 millimeters.
Okay, 6 millimeters. So what's the upper limit of vessel size to use the microvalve?
So the current iteration of microvalves go up to about 5.5.
My question is, if you used it in a 6 millimeter vessel, is there a downside? Like or it just would be rendered useless? You know what I mean?
So I think that's actually a fantastic question because that allows us to kind of talk about how I think the catheter actually works. All of these catheters, I think, have a series of mechanical effects and then also kind of physiologic vessel effects. And so let's start with the easy one, which is the vessel effects. The first one is it causes turbulence and turbulence of flow, which mixes the spheres that you're infusing into the artery just at the tip of the catheter. So you can imagine if you have a catheter facing one direction or another, it may preferentially push your microspheres one direction or another. And so, if you're at a vessel bifurcation, and you're facing towards one of the bifurcations, you can imagine a lot of your embolic material going into that one bifurcation versus equally between both. And you want it to go equally between both because then it's just the physiologic resistance of the tumor being less that's going to drive the increased, let's say, radioembolic material into the tumor. The second one is it puts you into the center. You can imagine you have a balloon expanded or you had a microvalve expanded. The tip of your microcatheter is going to be in the center of the vessel. Again, that just leads to allowing homogeneous perfusion into both sides. The third one is the anti-reflux properties of a catheter. And so you can imagine if your microvalve wasn't fully occluding the vessel because it was too big, you may not get the anti-reflux properties. But for the most part, as long as it's not dramatically too big, you're still going to get the homogenizing of the flow and vessel centering properties, if that makes sense, because you're still relatively going to be centered because the microvalve is kind of pushing 5.5 millimeters or the balloon's pushing 5.5 millimeters either side. Now, the interesting part actually comes when you start talking about the physiologic effects. And I think as we're looking at this case, I think the physiologic effects is really where the idea of pressure modulation comes into play. Because all of the first effects that we were talking about is increased pressure. But a lot of the redistribution I actually think comes with decreased pressure. So there's a lot of research, again, a lot of it done by Steve Rose, the guy who mentored me and trained me, showed that when you expand these microvalves, at the tip of your microcatheter, the pressure is significantly decreased. And so this is where it gets a little, you have to imagine this in your head a little bit. But if you have two compartments, you have a high pressure compartment, which is your systemic arteries, and then you have a low pressure compartment, which is everything distal to your occlusion catheter, whether it be a balloon or a microvalve. Everything distal is going to have different physiology. So one of the ways these microcatheters, I think, work is when the hepatic artery has a decreased relative pressure, suddenly the normal arteries are going to constrict because the liver wants a normal blood flow, right? So you can think of your trauma patient, all of the arteries are clamped down, right? Because the body's really trying to maintain perfusion pressures. And so all of the arteries in the liver are clamped down and trying to maintain the pressures that you just dropped. The tumor can't do that, right? We talked about not having the neural components do it earlier. And we talked about not having the smooth muscle components do it, right? It can't clamp down. So now you have all of these clamped down arteries in the normal liver vasculature and a relatively similar unclamped down, maximally dilated tumor arteries that are irregular. You have redistribution of the flow, preferentially more towards the tumor. That's one thing that could be happening. The second thing that could be happening now is imagine if you have a tumor in segment 8 and you create a downstream, vascular compartment by, having these catheters in there. You have a drop in pressure. Now you have intrahepatic collaterals from, let's say, segment 4 and segment 7 that are still at systemic arterial pressures because you haven't occluded them. They're going to be pushing into segment 8, right? Because they're going to go from the high pressure to the low pressure, just like water goes from, uphill to downhill. And so you're going to now have redistribution of the intrahepatic collaterals where everything is going to be pushing into your segment that you're going to be treating, again, with the tumor being the least resistive path for the blood flow to go. And so you have decreased pressure, which can modulate how your embolic material, whether it be chemoembolic or radioembolic, gets delivered into the tumors. Now, you're going to say, you're just full of it. That's BS. What evidence do we have for any of this? Like I said, a lot of the stuff was first noticed very early on by the Japanese. Like I said, 1991 is when this was all discovered. And since then, a lot of people have looked into when do we see this redistribution of the flow? And so if you look at the balloon occlusion taste data, they talk about this concept of a balloon arterial stump pressure, BOASP. And they say that if you get it below 64 millimeters of mercury, that's actually when you see the redistribution of the flow. If you actually don't get it below a threshold, you don't see redistribution. The second piece of evidence is people were looking in the early 2010s of ways of improving this T to end ratio that we were talking about. And a lot of interest was put into a drug called angiotensin II. I'm sure we all have long since forgot about it since our med school days. But the general concept of it in the kidney, at least, was to maintain pressure, where if they had decreased perfusion pressure to the kidney, it would secrete this hormone, which would act as a vasopressor, right, to increase the flow to the kidney. They were doing that for liver tumors, and they were injecting vasopressin into the arteries and seeing, did that actually alter the T to N ratio? And it did. Again, through that same concept. You're injecting something that's going to make normal arteries constrict. The tumor can't do that. You have redistribution of flow. And then if you look at the only randomized control trial that was done with a Surefire device, again, the early generation microvalve, they saw no difference in the randomized arms to a normal catheter and a microvalve catheter. Interestingly, though, because as we were talking about the early device, they had a lot of spasms, every single patient got treated with nitroglycerin. And so a lot of the benefits that you were getting from the vasoconstriction might have been alleviated because they were given the nitroglycerin. So that's how I think all of this works. And I think a lot more research is being done now that we're starting to get a lot of focus into it. But it is a really cool concept that involves physiology just above and beyond an anti-reflux catheter.
So actually, one of the explanations regarding physiology makes a lot of sense. So if you're cutting off or reducing the blood flow to segment 8, then the normal vessels clamp down, but the tumor vessels cannot, and so they're dysregulated, and they're going to then receive more blood flow than the rest of the vessels. I have to back up on is if you decrease blood flow to segment 8, and then all of a sudden collateral flow comes from adjacent segments, I guess what I would be concerned about in the back of my mind is those collateral vasculatures pulling from adjacent segments would then supply the tumor, and that's actually like either washing out your drug delivery or reducing the efficacy. Do you know what I mean?
Totally. And you definitely, anyone who's done this has seen that, right? The paradoxical effect where everything seems to go the complete opposite direction of what you wanted. In my experience, I see that more with balloon occlusion catheter, because again, going back to what we were talking about, you completely occlude antegrade flow. Now, again, that's a lie. There's, still some antegrade flow through vasa vasorum, but for all intents and purposes, you obliterate all antegrade flow. The microvalve, one of the benefits of it is that you're still having antegrade flow every single systole. Now, have I seen it happen with a microvalve? Of course I have. I'm sure if, you do hundreds of these, you see everything. But for the most part, the chance of having that paradoxical effect, I've seen it less with using a microvalve because antegrade flow is being maintained. But you do have to be very cautious of that. And that's why if you are going to use it, I definitely recommend a cone beam CT just to make sure you actually are seeing the physiology that you're expecting. And you're most commonly going to see this in segment 8 and segment 4, kind of the watershed areas of the liver.
Okay, good tip. Let's do some more cases.
All right, next case. And sorry for that diatribe about physiology.
No, that's awesome. I mean, that's like, I always like the assumption is like if I'm into it, like the audience is into it. And so I don't know. I think the people who like tend to listen to BackTable podcasts are the ones who want to geek out on this stuff. So I just assume they're into it.